We shall move on to our next speaker, Dr. PRATHEEBA Devi, who's again practicing good oculoplastic surgery in MNI Hospital, Chennai, and very popular figure in the field of oculoplasty. And she's going to tell us something what we're already discussing. How do you do a systemic evaluation for our DCR patients? On to you, Dr. PRATHEEBA. PRATHEEBA, you are muted or what?
Yeah, sorry. Good evening, everyone. Thank you, madam, for the introduction and giving me the opportunity today to speak in this webinar. So my topic is on systemic evaluation. Dr. Sonam has beautifully covered the ophthalmic evaluation of epiphora. So my topic is more simple, and it is going to be the pre-operative systemic evaluation. So systemic evaluation, when we talk about it, is mainly the systemic parameters and then the nasal endoscopy. So when it comes to systemic evaluation, the detailed history is very, very important. And then doing a proper blood evaluation is mandatory. So when it comes to history, a detailed medical history should be prompt and asked to the patient, because patient may not come out with those histories. They should be asked about history of supplements. They should be asked about history of scarring tendency. They should be asked about history of cold urticaria. So when you talk about medical history, we should ask the common question. We should ask about the intake of non-steroidal anti-inflammatory medicines, the oral anticoagulants, history of liver pathologies, history of prolonged bleeding episodes. So why is NSAD important in this aspect? So traditional NSADs, they block both cyclooxygenase 1 and 2 pathway. Cyclooxygenase 1 is responsible for the platelet function. So when that is blocked, the platelets function is affected and there is a prolonged bleeding in such patients. So ideally, NSAD should be stopped 5 to 7 days prior to the surgical procedure. And when we talk about anticoagulants like warfarin, heparin, and vitamin K antagonists, people are given these medicines to prevent thromboembolic episodes. These medicines are given to prevent a thrombus, and so they cause increased bleeding tendency on table if they are not stopped. But several studies have shown that if these medicines are stopped abruptly, then they can cause a rebound hypercoagulability. So these in high-risk patients, proper clearance should be obtained from their treating physician. And even some physicians have reported that they give a bridging therapy with either a low molecular weight heparin or an unfractionated heparin during the surgery to prevent such thromboembolic events. So there should be a right balance between the risk of increased bleeding and such post-perioperative thrombotic complications, which are dreadful. So what we should do, ideally, we should get a proper clearance, stop all anticoagulants 5 to 7 days before surgery. And it is reasonable and wise to check the INR and consider postponement of surgery if the INRs are above 3. And this is another important aspect. We see a lot of patients taking herbal supplements, which contains bilberry, chamomile in green tea, vitamin E in creams, fish oil, flaxseed oil, garlic, ginger paste. So these things are said to cause increase in bleeding. Leave about DCR, we deal with many cosmetic procedures. These herbal supplements are prone to cause more edema and bruise post-operatively. So our patients should be warned about the risk, so that they are not very unhappy post-operatively because of the bleeding and because of the bruise and hematoma. So what can happen if these anticoagulants are not stopped? It can cause a simple lead hemorrhage or a prolonged bleeding to a dreadful orbital hemorrhage. So a dreadful orbital hemorrhage can lead to vision-threatening complications. Though rare, it should be kept in mind. So these things should be inquired and stopped and get a clearance accordingly. And in such patients who are on chronic therapy, the patients have to be taught about the risk of these complications and the symptoms which they develop. And these patients should be given advice to report to the emergency once they see symptoms of orbital hemorrhage, like increase in proptosis, prominent edema, or in case if there is a poor red desaturation test, which is suspicious of optic neuropathy, they should report to the emergency immediately. So our patients should be taught about these in high-risk patients. And history of cold urticaria, though not very common in our country, history of cold urticaria should be asked, And if there is a history, immediate cold compress to reduce the edema should not be advised, because that could be potentially fatal in these patients. And coming on to the blood investigations, I routinely do the common basic blood tests like hemoglobin, TCDC, ESR, blood urea, creatinine, and bleeding time, clotting time with INR, and random blood sugars, the hepatitis and HIV profile. And I do a COVID testing these days. So this was also discussed. So I do it as an elective procedure. If they are COVID positive, I, based on Dr. Javed's practice guidelines, we can triage the patient, and if it is an urgent surgery requiring an emergency treatment, then we can take up a COVID positive patient. Otherwise, we can wait for the patient to become COVID negative and take up the patient. And if they are COVID positive, sir has given beautiful guidelines. We can follow those guidelines if we are operating on a COVID positive patient. And many of our DCR patients, as already discussed, most can be done in local anesthesia. But if they require general anesthesia, particularly if it's a pediatric patient or if it's a highly anxious patient, then we have to do all these detailed evaluation which our anesthetist ask, and get proper fitness, including cardiac fitness if needed.
1 minute left.
And this is very important, nasal endoscopy. Nasal endoscopy involves evaluation of nasal and sinus passages. So it's an OPD procedure. So technique of endoscopy, the nasal packing, as Dr. Kruti has already pointed upon, I inject the nasal spray and then I pack the nasal passage with gauze soaked in Otrivin drops and lignocaine with adrenaline for at least 10 minutes before the procedure. And this is the endoscopic unit which I have, and then I do the endoscope. So what do I see? I see for the DCR site. So this is the middle turbinate. This is the root of the middle turbinate. I see for the space here, which is available. I see for any mass or any polyp. I see for the septum. I see for any septal hump or spur. And I see for the nasal mucosal abnormality. So why to do to prevent intraoperative surprises and to avoid postoperative disappointments, and missing a tumor can be a medical legal issue as well. So this is a small video of nasal endoscope. So here, so we start from the anterior aspect. This is the inferior turbinate which we see here. And then we go back. And now what we see here is the middle turbinate. And this is the root of the middle turbinate. This is the site of our endoscopic DCR incision. And then we go through the inferior meatus. This is the first pass. We go through the inferior meatus. And this is the nasopharynx. And then we come up and the middle turbinate, the middle meatus, the openings in the middle meatus, and the bulla ethmoidoilis. So this is a normal nasal endoscope with a healthy mucosa and with no abnormality. So this is a grossly deviated septum, and when we deal with grossly deviated septum, we will have to do the repair and then take up of surgery. Otherwise, we will end up in failures. And there's a polyp here, and there is a tumor, cauliflower-shaped lesion here. So a nasal endoscope helps us to plan preoperatively and to avoid disappointments postoperatively. So when there is any other abnormality, an ENT specialist should be, a consultation should be done and treated appropriately. And according to literature, the common causes for failure of DCR are anatomical, pathological, and surgical, among which anatomical and pathological causes are the major chunk, which could be definitely avoided if we do a proper nasal endoscope. So the take-home message is we have to do a proper systemic preoperative assessment, do a detailed blood evaluation, and also do a good nasal endoscopic evaluation before a DCR to have a successful DCR. Thank you. Thank you for the opportunity.
Thank you, Dr. Prathiba. Such a thorough talk. You answered all the questions which I had for you. That tells that how deeply you went into it and gave us all that we needed to know. Dr. Arvind, would you take some questions with that?
Dr. Prathiba, thank you for a very wonderful endoscopic video.
Thank you, sir. I should acknowledge Dr. Sumati, our ENT consultant, for the video. Thank you.
Not the last slide acknowledgement, but really that kind of put things in place.
Yeah.
My question is to Dr. Saptagirish. Do you recommend pre-medication for any of your DCR patients? Is it a part of your routine?
Hi, Arvind. I usually do not give any pre-medication as a routine. But I know my colleague in my colleague here does give little Restil, and he gives a pre-operative painkiller also and all that. But I, as a routine, do not give. I perform most of my surgeries under local anesthesia, as Dr. Lakshmi Mahesh mentioned, and most of the patients are comfortable. Most of my practice is only external DCRs. I don't do much any endoscopic DCRs. It's just the opposite of what Dr. Javed does. And yeah, I mean, that's the patient profile that I have. It depends on that. And I don't do any pre-medication per se. But yes, if as Dr. mentioned, Prathiba mentioned that if the patients have little bleeding disorders, or in a preoperative evaluation shows up that the patient is prone for bleeding, our anesthetist is consulted. We'll have a consultation with the hematologist, and we either keep a fresh frozen plasma or blood or what platelet extracts ready. And we do, if it's required, we do need to give it, we give it. But it is less. Most patients are quite stable. We do a good preoperative evaluation. So preoperatively itself, we've had patients where we've given them preoperative plasma and stabilized their INR and then taken up for surgeries. Patients who are already on anticoagulants, we ensure that the hematologist and the cardiologist give clearance before we even take it up. And of course, the INR is the thing that we look at, and that gives us some value, but nevertheless, bleeding can still take place. You do have small vessels which can bleed. It's mostly the capillaries which can cause a lot of bleeds rather than the major vessels, because you can always coagulate the major vessels or cauterize them. But the small capillaries are the ones that keep on bothering you. And so preoperatively, apart from the pre-op evaluation, pre-op preparation as such, no, I don't give anything much. I don't trouble my patients much. But yes, my colleague believes in giving Restil, and I'm sure many of them do it. I used to do it much earlier, but I don't do it now.
Thanks for emphasizing on the preoperative evaluation. I think we all agree that DCR is not a minor procedure. It does involve a lot of systemic features, and a good preoperative evaluation will ensure a smooth surgery and a good post-op outcome. I'll just pass this question around to the other panelists, Dr. Ravindra Mohan and Dr. Lakshmi Mahesh. Any choice of pre-medication as a routine for DCR patients?
Yes, I give Otrivin nasal drops 3 times a day, both nostrils, 3 days before the procedure for all DCR patients, endoscopic and external, all the more for endoscopic. And I also give Otrivin pediatric or NIVEAN pediatric nasal drops 3 times a day before probing and syringing. It makes a difference, because I learned the endoscopic DCR the very hard way. Started sometime in 1996, and I realized that this works. And pre-operatively, I make sure the aspirin also is stopped at least 3 to 4 days prior. And if the patients are on clopidogrel or warfarin or Coumadin at least a week prior, get a cardiology, because patients are psyched about stopping it. I ask them to get an evaluation done and stop it 1 week prior, because most of the times it's the bleeding which is so annoying. And I think for all said and done, it's a keyhole surgery, whether you're doing it externally or endoscopically. And hemostasis is definitely the key.
Yes. Thank you very much, Dr. Lakshmi.